Welcome to the Ross University School of Medicine's Procedural Skills Airway Management Lecture Presentation. I'm Dr. Brenton Otey, and I'll be guiding you through this lecture today. Let's start by looking at some of the objectives. The objectives are to introduce students to various airway maneuver techniques, discuss the role of airway adjuncts in airway management, provide training for airway adjuncts and bag mask ventilation, and lastly, to discuss concepts related to successful airway management in critical situations. Let's take a look at our schedule. We're going to start with an introduction, review of some of airway and oxygenation devices, and have a demonstration of airway adjuncts and bag mask ventilation, followed by some practice by the students. Before we get started, I'd like to discuss some concepts. Want to remember that airway management is not intubation. And also, oxygenation and ventilation are the main priorities in acute airway management. Let's look at some causes of inadequate ventilation. Primarily, respiratory effort and airway obstruction. So some issues with respiratory effort, they can be intrinsic factors or extrinsic factors. Intrinsic factors, an example being intracranial hemorrhage, or an extrinsic factor such as an opioid overdose. As we remember, opioids do suppress respiratory drive. Some examples of airway obstruction include soft tissue airway obstruction, most often the tongue, lodging of foreign bodies, perhaps the injured tissue, or even blood and secretions such as mucus can cause significant airway obstruction. Now let's talk about the airway maneuvers. In this presentation, we're going to cover these three listed here: the head tilt chin lift, the jaw thrust maneuver, and briefly talk about the importance of cervical spine immobilization. Let's get started. The head tilt chin lift. This is the primary maneuver used in any patient for whom cervical spine injury is not a concern. Let's discuss the technique. Use two hands to extend the patient's neck, opening the airway. With one hand applying downward pressure to the patient's forehead, use the tips of the index and middle finger of the second hand to lift the mandible at the mentum. This lifts the tongue from the posterior pharynx. Now the jaw thrust maneuver. This is an effective airway technique to be used in a patient for whom cervical spine injury is a concern, as the jaw thrust is the safest first approach to opening the airway if the patient has a suspected neck injury. Here's the technique. The patient should be supine. Place the heels of both hands on the parieto-occipital areas of each side of the patient's head. Then, while grasping the angles of the mandible with the index and long fingers, displace the jaw anteriorly. This maneuver moves the tongue anteriorly with the mandible, minimizing the tongue's ability to obstruct the airway. And lastly, let's discuss cervical spine immobilization. The clinician must act to stabilize the cervical spine to minimize head and neck movement in a patient with a suspected cervical spine injury. Because remember, we want to minimize the risk of exacerbating the cervical spine injury in the patient. Now let's discuss the airway adjuncts. What's their purpose? Once an open airway has been established, it must be maintained. The airway adjuncts prevent airway occlusion by the tongue. Here are the two types of airway adjuncts we're going to discuss in this presentation. The oropharyngeal airway, also known as an OPA, and the nasopharyngeal airway, known as an NPA. Note that neither of these airway devices will protect the trachea from aspiration of secretions or gastric contents. An endotracheal tube should be inserted as soon as possible in any patient unable to protect his or her airway. You'll also see there is an oropharyngeal airway pictured here. Now let's discuss the oropharyngeal airway in detail. It is only to be used in an unresponsive patient who is unable to maintain their airway. This is because it may cause vomiting and aspiration in a responsive patient. The OPA is a curved hollow tube with a rectangular opening. This is used to maintain a channel between the mouth and the glottis, preventing obstruction by the tongue or other soft tissue. And there's multiple sizes to choose from depending on the size of the adult that we're working with. How do we measure? Well, use the angle of the mandible. Hold the OPA beside the patient's mandible, orienting it with the flange at the patient's mouth and the tip directed towards the angle of the mandible. If properly sized, the OPA should just reach the angle of the mandible. In here, we have a demonstration pictured here. As you can see, the tip is just reaching the angle of the mandible of the patient. Now let's talk about insertion. Try to avoid pushing the tongue into the posterior pharynx. Start with the curve of the OPA, inverted, directed cephalad, then rotate it about 180 degrees as the tip reaches the posterior pharynx. Alternatively, a tongue depressor can be used to move the tongue out of the way as the airway device is passed. Now, let's talk about the nasopharyngeal airway. The NPA is a soft rubber or plastic hollow tube that is passed through the nose into the posterior pharynx. Please note that patients tolerate NPAs more easily than OPAs. So, NPAs can be used when the use of an OPA is difficult, such as when the patient's jaw is clenched or the patient is semi-conscious and cannot tolerate an OPA. There are also multiple sizes to choose from. The sizes are based on the internal diameter. The larger the internal diameter, the longer the tube. Note, we generally have a length of 8 to 9 centimeters for a large adult, an NPA with a length of 7 to 8 centimeters for a medium adult, and 6 to 7 centimeters for a smaller adult. How do we measure? Well, hold the airway beside the patient's mandible, oriented with the flared end at the tip of the patient's nose and the distal tip directed towards the angle of the mandible. If properly sized, the tip of the NPA should just reach the angle of the mandible. In terms of insertion, the NPA is inserted along the floor of the nares into the posterior pharynx, behind the tongue. Note that prior to insertion, the NPA should be coated with water-soluble lubricant or anesthetic jelly. The tube can also be rotated slightly if resistance is encountered. In terms of bag mask ventilation, successful bag mask ventilation depends primarily on 3 things: having a patent airway, maintaining an adequate mask seal, and proper ventilation. In terms of mask placement, there's 2 different techniques that can be deployed: the single-handed technique and the two-handed technique. The two-handed technique is preferred for bag mask ventilation. Here we have pictured a bag mask ventilator. As you can see, there's the mask component and the bag, which is the reservoir for the air. The fractional inspiration of oxygen is 100%. Keep in mind that this is difficult to use on an awake patient because we must coordinate the inspiration and expiration. Mask placement for the bag mask ventilation is very important. You're going to detach the bag from the mask prior to mask positioning. The nasal portion of the mask should be spread slightly and placed on the bridge of the patient's nose. The body of the mask is placed onto the patient's face, covering the nose and mouth. Let's talk about the single-handed technique. One hand is placed on the mask with the web space between the thumb and the index finger resting against the mask connector. Web space is placed in the center of the mask, allowing for a more even application of pressure. The middle, ring, and little fingers are placed along the mandible, up into the mask, in a chin lift maneuver. This opens the airway further. As you can see pictured here is the CE technique for bag mask placement. The pointer, the index finger, and the thumb form the C around the mask, while the ring, middle, and little fingers form the E along the mandible. The correct technique is to lift the mandible up into the mask with the middle, ring, and little fingers while holding the mask tightly against the patient's face with the thumb and index finger. This ensures that you have an adequate mask seal. Now, let's talk about the two-handed technique. This is the most effective method of opening the patient's airway while maintaining an adequate mask seal. This requires two providers, unlike the single-handed technique. One provider has the sole responsibility of using both hands to create a good mask seal and to maintain an open airway. The second provider is going to ventilate the patient by squeezing the bag. Proper placement and holding of the mask are essential for a good seal. But what are some problems you may encounter when using the bag mask? Well, if there's obstruction to airflow or lack of chest rise when ventilating, consider the most common causes. Inadequate mask seal. Perhaps if there's a patient with facial hair, they may need some sort of jelly or water applied to improve the seal. Improper mask seal. Ensure that the corners of the mouth and all airway adjuncts are inside the body of the mask, not creating a leak by interfering with the mask seal. Perhaps there's a lack of airway adjuncts. Verify airway adjuncts are being utilized and in proper position. Inadequate airway maneuvers. Ensure the jaw thrust and other maneuvers are being done effectively in order to open the airway. And lastly, inexperience. Determine if a more experienced clinician needs to be recruited to help provide optimal bag mask technique, particularly the mask seal. And lastly, let's discuss ventilation and some errors to avoid. Try to avoid giving excess tidal volumes. Remember, the average tidal volume of an adult, about 75 kilograms, is 500 milliliters. So keep that in mind. Also try to avoid forcing the air too quickly or ventilating too rapidly.